Alterations in elimination, renal, disorders of the bladder and urethra. Urinary retention is the inability to urinate or effectively empty the bladder. It can be acute or chronic, and we often see residual urine. Acute retention is seen in complete urethral obstruction after general anesthesia or with certain drugs, and these clients are unable to void at all. Chronic retention is seen with conditions such as prostatic enlargement or neurologic disorders, and these clients are able to void, but they're unable to empty the bladder and they have a large residual volume. It is most common in older men, especially age 70 or older. These clients will have a sudden inability to void. The bladder will be distended. They may have severe lower abdominal pain in acute retention, but with chronic retention have difficulty in starting the stream of urine. They continue to feel the urge to void despite having just voided. Bladder infections are very common, and they may also experience dribbling of urine. We diagnose by looking at a urinalysis, catheterization, or ultrasound. Acute retention is treated with immediate catheterization. Chronic retention may require a permanent drainage tube, such as a suprapubic catheter, may involve the use of the Credé maneuver, where you manually put pressure on the bladder, or the Valsalva maneuver, may require intermittent catheterization, and for men might require surgery. Nurses should monitor I&O, palpate the bladder for distension, and monitor for any UTIs. True or false? The customary solution for urinary retention is developing a permanent drainage system. This is true. Urinary incontinence is the inability to control the voiding of urine. It does occur in at least 1/3 of older adults in the community and 1/2 of older adults that live in institutions. It is considered to be a psychosocial and physical problem. The bladder, urethral dysfunction, or failure of the urethral sphincters to hold urine are potentially the cause. There's numerous risk factors for incontinence that are listed in your textbook, and I'm going to let you review those there. We do know there are several drinks or medications that can also increase the risk for temporary urinary incontinence, such as alcohol, caffeine, decaffeinated tea and coffee, carbonated drinks, artificial sweeteners, corn syrup, foods that are high in spice or sugar or acid, heart or blood pressure medications, sedatives, and muscle relaxants, in addition to large doses of vitamins B or C. These clients will experience urgency, frequency, leaking small amounts of urine when they cough or sneeze, or an inability to control urine at all. We diagnose with a urine culture and sensitivity, a cystoscopy, cystogram, urodynamics, or a pelvic ultrasound. The aim of treatment will be the correction of the disorder. It may require some pharmacological agents or types of surgeries. Nurses should strive to prevent skin breakdown, reduce anxiety, provide bladder training, teach Kegel exercises, encourage the wearing of barrier garments or external collection devices. Cystitis is inflammation of the urinary bladder, usually from a bacterial infection. We frequently call it a UTI. It can be caused by invasive procedures, fecal contamination, prostatitis, BPH, indwelling catheters, pregnancy and sexual intercourse. With prostatitis and BPH, that could be from urinary retention. Cystitis is more common in women due to the short urethra and the proximity of the urethra to the rectum. These clients will feel pain, urgency, frequency, low back pain, dysuria, and cloudy or strong smelling urine, and sometimes hematuria. We diagnose through microscopic examination, a culture and sensitivity, IVP, or a cystoscopy for repeated episodes. We treat it with antimicrobial therapy and the encouragement of cranberry juice. Nurses should encourage fluids and teach prevention methods. True or false? To treat cystitis or a bladder infection, ingestion of cranberry juice or vitamin C is recommended. This is true. Interstitial cystitis is also known as painful bladder syndrome. It is a chronic inflammation of the bladder mucosa. These clients will have frequent painful urination with small amounts of urine and painful intercourse. We diagnose with a cystoscopy, urinalysis, biopsy, or cystourethrogram. Treatment may involve a bladder instillation of dimethyl sulfoxide or silver nitrate, laser therapy, or drug therapy. Nurses should encourage the client to avoid spicy and acidic foods, carbonated beverages, caffeine, citrus products, and vitamin C, in addition to providing psychological support, as interstitial cystitis, being a chronic disease or inflammation, can cause significant alterations to a person's lifestyle. Urethritis is inflammation of the urethra. It can be caused by microorganisms. It is more common in men than women, and it can accompany cystitis or vaginal infections in women. These clients experience dysuria, urinary frequency, and urethral discharge. We diagnose by doing a urethral smear in men and a urinalysis in women. We treat it with antibiotics, a liberal fluid intake, analgesics, and warm sitz baths. Nurses should encourage the completion of the antibiotics and encourage frequent perineal care, especially if an indwelling catheter is in place. Bladder stones are stones that have formed in the bladder or the upper urinary tract that might migrate to the bladder. It can be caused by urinary retention, urinary stasis, an enlarged prostate, and immobility. These clients may experience hematuria, cloudy or dark urine, suprapubic pain, difficulty starting the stream of urine, or pain with urination. We diagnose with a cystoscopy, a KUB study, an IVP, ultrasound, or a 24-hour urine collection. We can treat it with a litholapexy, surgical incision, a low purine diet, and increased fluid intake. Nurses should perform intake and outputs, encourage fluids, and provide client education on straining urine so we know when any stones have been passed. Tests can also be done on the stones to determine the makeup of the stone. In other words, is it something in particular that the client is ingesting that is causing the formation of the stones? Urethral strictures are narrowing in the urethra, and that can obstruct the flow of urine. This can be caused by infections, trauma, or it can be congenitally acquired. It can lead to bladder, ureter, and kidney pelvis distension because of urinary obstruction. Bladder distension can also cause diverticuli. These clients will have a slow force of urine, hesitancy, dysuria, urine retention in the bladder, nocturia, and lower abdominal pain. We diagnose with a cystoscopy, an IVP, or retrograde pyelogram. We treat it with dilation or a urethroplasty. Nurses should educate clients on hematuria or burning with urination, especially post-dilation, encourage fluids, and instruct clients to complete their medications as prescribed. Bladder cancer is the most common urinary system cancer. It occurs more in men than women, and it's often caused by the use of tobacco products, carcinogen exposure, chemical or fume exposure, and recurrent UTIs. These clients may experience painless hematuria, a change in the color of urine, UTI symptoms, anorexia, and weight loss. We diagnose by microscopic biopsy, cystoscopic examination, retrograde pyelogram, CT scan, X-rays, and ultrasonography. We treat it with coagulation, anti-neoplastic drugs, photodynamic, radiation therapy, cystectomy, and bladder resection. This might require a urinary diversion procedure and a urostomy, an ileal conduit, continent urinary diversion, and uterosigmoidoscopy are the different types of ostomies that can be performed. With a ureterosigmoidoscopy, this is where the urine will drain continually into the rectum. Nursing management includes pre- and postoperative care, emotional support, and enemas preoperatively. So a client is suspected to have bladder stones. How many hours should a urine sample be collected for as part of the diagnostic workup? That's 24 hours. Trauma can occur from gunshot or stab wounds, crushing injuries, and forceful blows to anything in the genitourinary tract. In other words, it can damage the kidneys, the bladder, the ureters, or the urethra. It results in tears, hemorrhage, or penetration that can cause urine to leak into the peritoneum, and damage to the kidney may result in bruising or tearing. These clients may experience anuria, hematuria, pain in the abdomen, and symptoms of shock. We diagnose with abdominal x-rays, cystoscopy, IVP, or exploratory surgery. Surgically, we're going to repair the wound, potentially do that nephrectomy, a cystotomy, a cystectomy, or place an indwelling urinary catheter. Nurses need to recognize abnormal findings, and if a nurse is inserting an indwelling urinary catheter and blood is noted, the nurse should immediately notify the healthcare provider after a client has been involved in some type of trauma.